Hello, good afternoon. Welcome to FMDA, the second journal club of 2024. Thank you for all coming to listen to our live session. Please bear in mind that it will be recorded. We wanted to extend our gratitude to Dr. Diane Sanders-Cepeda and to the FMDA crew for giving us this opportunity to moderate these sessions. For those that don't know me, I am Dr. Kenya Rivas. I'm family medicine and geriatrician by training. I work at the university setting many years with Dr. Pandya and Dr. Elizabeth Hames. Now I'm working as a system team lead in the post-acute management at United Health Group, Upton. And it is my pleasure now to introduce Dr. Elizabeth Hames, who has been my partner in crime, my friend for years, I'm not going to say 10 years, with whom I have the privilege to host these sessions. So Liz, the floor is yours.
Thanks so much, Kenya. It is my pleasure to introduce our speaker for today, Dr. Naushira Pandya, a friend and colleague, and she is professor and chairman at the Geriatrics Department, Kiran Patel College of Osteopathic Medicine in Fort Lauderdale. She is also project director for the South Florida Geriatric Workforce Enhancement Program, GWEP, a HRSA-funded grant project. And she's contributing so much to the field of geriatrics. She is an AMDA past president. She is a geriatrics fellowship director, a Fulbright scholar. She's been a panelist at the White House for Conference on Aging and Antimicrobial Stewardship. All around wonderful person and a great contributor to the field. So it's my pleasure to turn the floor over to her for her lecture today, Diabetes Management in Post-Acute and Long-Term Care and Update. Thanks.
Okay, thanks so much, everybody. Can you see my slides? The slides
Yes.
Yes. Okay, thanks. I'm going to give, we have an hour, right? For this presentation?
Yes,
I'm going to go fairly quickly through some of the material because I think the discussion time is important. And, you know, I'll probably share this with you when I'm, when the AMDA guideline is more ready for publication. I think that's when we'll send you most of this information. So my disclosures are, of course, this work is, a lot of the work is supported by the grant we have from Health Resource Service Administration. And I have been a consultant, a long-time former speaker for Sanofi, but I'm really not doing much work with them right now, but that is a disclosure. But that will not affect the content or the recommendations in this presentation. So I'm going to talk first about strategies to optimize diabetes management in the post-acute long-term care setting. The use of newer agents, well, they're not really that new anymore. The GLP-1s and the SGLT2 and 1 inhibitors. But the application, I think, is something that's still worth repeating, and we need to think about it in our patients. And as somebody said very recently in a long-term care webinar, you know, our patients are not all frail elderly anymore. Some are younger, some are they're more rehab patients, and a lot of them have the potential to go home. And I'll talk about potential applications and benefits of wearable technologies, and I'll just focus on continuous glucose monitors for now. Okay. So I just want to bring this concept, you know, part of the big push in the Health Resource Service Administration and with the Institute of Healthcare Improvement is to use this 4M framework of mentation, medications, mobility, and what matters most in the care of older adults. So I applied this to diabetes. So this is kind of my take on how you can use the 4M framework when you're thinking of the older adult with diabetes. So mentation, you know, do they have dementia, depression? What are their coping skills? Diabetes distress, and that affects the use of technology. Medications, we are all familiar with this, propensity to cause hypoglycemia. What kind of affordability do these medications have? How do you select them with end organ problems? And mobility, diabetes affects mobility severely. Not only can it cause frailty and sarcopenia and leg weakness, but foot complications can affect mobility, function, neuropathy, and loss of vision or impaired vision. And then the M of what matters most. Many things apply here when you think about diabetes. Advanced care planning for one, where they are in the diabetes trajectory, where are they in the course of the disease? And that, so you have to think about macro and microvascular complications, what their present quality of life is, the support system, and what burdens are they experiencing right now in the management of disease, and what are their treatment preferences. For instance, some people will absolutely refuse, no matter what, to have injections as part of their therapy. So that all needs to be taken into account, documented and negotiated. And, everything you recommend may not always work or be accepted by the patient. We're all familiar with this picture of geriatric syndromes found in older adults, polypharmacy, falls, increase in pain, cognitive impairment. Just to be clear on the complications, depression is now recognized as a complication of diabetes. People are twice as likely to have depression if they have diabetes, about 1.5 times more likely to have cognitive impairment. The other thing I want to point out is the risk of fractures. So diabetes is now, both type 1 and 2 are recognized as potential causes of bone loss. And in fact, the T-score threshold, which I'm just learning from people who are doing work in bone disease, is -2. We would treat osteoporosis if the T-score was less than 2.5, or the FRAC score was elevated. But for diabetes, the threshold is lower. So this is something we'll learn more about as time goes on. But I'm starting to do bone densities now on everybody with a long history of diabetes, and it's not being turned down. Before we move further, I just wanted to say a word about type 1 diabetes. And Dr. Hames and I and our fellow, we covered this issue in our article on diabetes in Diabetes Spectrum. And Ruth Weinstock has talked about it much earlier in 2016 in Diabetes Care. But we have to recognize that people with type 1 diabetes are living longer. So some of them are in the long-term care setting, where the risk is that we think that most people have type 2, but we could be wrong. And because records might be poor, we might not have caregiver engagement or family engagement, we might not realize that they actually have type 1. And so hypoglycemia can develop in diabetic ketoacidosis if they're not treated, or insulin is held for fear of hypoglycemia. Also, they can become severely hypoglycemic with acute infection, cardiovascular, or other emergencies. And that acidosis and diabetic ketoacidosis may be mistaken for organ failure or sepsis, and that could certainly occur. But we have to think about diabetic ketoacidosis. And so more education is necessary. We will soon see people who are, and maybe we have them already in some facilities, who are using an insulin pump with a CGM, and some are using a closed loop system where the CGM talks to the pump and we don't have anything to do with it. It's all programmed. So there's a lot to learn as these people will come into long-term care. So this is something I've tried to create as a roadmap for what to do in various long-term care settings for people with diabetes. And so I've divided the nursing facility into skilled rehab, long-term care, and hospice and palliative care, and assisted living facilities into those with standard license and those with a special license for more extensive care. I'm just going to ignore that section for the special license because I've learned researching this in different states, that ability for assisted living facilities to do more is all over the place. So just ignore that section. But I do want to look at what the goals of care are in these different patient populations. So for instance, glycemic goals in skilled rehab, we don't rely on the A1C, and you might say, why? Well, because people from who come to skilled rehab generally come from the hospital, and there might be a complicated hospital stay. So the only A1C that really matters is when they came to the ER, okay, from their prior kind of treatment life, because during the hospitalization, they might have chronic kidney, worsening of kidney disease, transfusions, other illnesses, and anemia. So that can affect the A1C. So we rely on blood glucose targets in the long-term care setting for skilled. 100 to 200 is reasonable. And in the long stay population, the long-term population, which is here, again, reliance on A1C, not to say you never do an A1C, you can trend it, but just relying on that as a measure of control is not reasonable for the same reasons. They're sick, they're going in and out of the hospital, many are anemic, about 50–60% have some form of chronic kidney disease. So we want to avoid hyper and hypoglycemia. Same with hospice and palliative care. We want to avoid extremes of blood glucose levels. And in the ALF, we certainly want to avoid hypoglycemia, and their current A1C goals are less than 8%. We're working on the older adult sex guideline now, and that recommendation could change. We're not yet sure. Okay, so going down into the blue boxes, what should we think about in terms of care? For skilled rehab, while we're treating diabetes, we should think about the potential for discharge. So we should be planning the drugs, the intensity, the number of glucose checks, injections, depending on the ability of the patient and their support system. Those in the long-term care setting, for planning care, we should really think about cognition, what their prognosis is, their comorbidities, and what are their goals of care. For hospice and palliative care patients, really comfort and reducing complexity and complying with the patient and family wishes is a priority. In the assisted living, you still need to think about where they are in their disease and the complexity of disease of management, because the number of blood glucose checks or number of injections may not be feasible in the assisted living setting. And the trick is that in all of these settings, not only you have to think about the site of care, the type of patient, the goals of care, but then you have to think about what each one's risk of hypoglycemia is, renal function, cardiovascular risk, weight loss, frailty. So this is why this roadmap is being created, as to think about diabetes management by site, by type of patient, and then what do we do in terms of other care considerations. So this, I won't go into everything, but really in all these patients, you should think about foot care, oral care, regular skin checks, regular foot exams, which could mean not every day they receive care, and certainly when the provider sees the patient on scheduled visits, you need to look at the feet, okay? And other care considerations would be how often you're going to check blood glucose levels. In long-term care, how do you replace sliding scale insulin? And the recommendations are, you could, if they're receiving very little, you review the blood glucose levels in 2 weeks or so, and then you try to simplify the regimen. Of course, you do discharge planning. And in the long-term care setting, same thing. We really want to replace sliding scale in whatever situation we can, because it's really time and labor intensive and often not necessary. So that involves a lot of education, of course. And in hospice and palliative care, you certainly want to simplify and de-intensify the treatment and focus on comfort and care. In the assisted living, I think there's a lot to still be done in terms of doing good patient care, overall patient care, foot and skin care, set blood glucose parameters for notification. Certainly sliding scale is not feasible in the assisted living setting. So you should see the patient and try to simplify the regimen as much as you can. And we'll talk about that in a bit more detail. So the priorities for setting glycemic goals are, one thing, avoiding hypoglycemia at night. So studies with CGM at Joslin Diabetes Center specifically have shown that even patients who had A1Cs of 8.5, 9%, when they wore a CGM, they had hypoglycemia during the night. The other thing you want to reduce is variability, glycemic variability. And then select your optimal glucose range. And you want to avoid the extremes of hyper and hypoglycemia. And that's where CGM might really help us. So a complex table, but we updated this for patients living in ALF, community dwelling older adults, and then, people who are in the SNF for rehab, long-term care, and at the end of life. So I've really covered most of this, and you have to individualize care depending on where they are in their disease, how impaired they are functionally. And this is based on population studies looking at functional status and diabetes. And these are really consensus recommendations. So in the assisted living, an A1C goal, a reasonable goal might be less than 8%. Blood glucose levels 90 to 150 in the morning, but even 100 to 150 in the morning would be reasonable. In the skilled nursing facility, there's a range of recommendations, 100 to 200 milligrams at any time. Obviously, we try to stay closer if it's fasting into the 100s, and if it's postprandial at bedtime, you can go up to 180, 200. And in the long-term care setting, the long stay patients, again, we don't rely anymore just on the A1C. But on the other hand, you can't rely on just an odd lab glucose. You have to have a systematic way of checking blood glucose levels, and it certainly may not be AC and HS. Okay, and people who are barely on basal insulin or oral medications do not need 4 times a day blood glucose checks. Okay, so when you look at A1C, actually, I just want to backtrack to see if I've missed a slide on treatment. I don't think I have. So when you look at the A1C, just look at the context of that, because there are some pitfalls in interpreting the A1C. It goes up by age, race. African Americans run about 0.4% higher. Hypothyroidism, splenectomy, any of these low blood turnover situations can raise the A1C. On the other hand, the A1C can decrease if you have hemolysis, a recent blood transfusion, hemolytic anemia, liver disease, or even erythropoietin therapy. So the context of interpreting the A1C is important, which I don't think most people are doing right now. Over on the left, the A1C can be increased by metabolic acidosis and uremia. So, there are a lot of factors that you have to look at when you look at the A1C, but certainly look at what's the hemoglobin, have they got a transfusion, are they hypothyroid, do they have some kind of bone marrow problem where there's a low turnover situation or iron deficiency. So that's interpretation. So from that, I sort of developed this roadmap, and this was also taken with the help of colleagues who are with the International Geriatric Diabetes Society, where we had a lot of discussion. So we decided, well, what is the really important thing when you select medications in older adults? Well, renal function really matters. So we looked at GFR less than 30, or on dialysis, or GFR greater than 30, hypo and hypoglycemia risk. Now, with all those issues, the weight status of the patient really matters. So starting from left to right, I looked at if they have renal failure, say stage 4 or 5 or dialysis. If they have normal appetite and no weight loss, then you have a little bit more choice, but not a lot of choice. You can certainly use basal insulin. You can use GLP-1 receptor agonists, and you can use a DPP-4 inhibitor. And I prefer linagliptin because there's no renal dose adjustment. The next box, in the same renal patient, but if you have low body weight and frailty, you really cannot use a GLP-1 receptor agonist because of GI side effects and weight loss. You cannot use that. So it cuts down the choice to insulin or DPP-4 inhibitor. Now, if your GFR is slightly better, normal appetite, no weight loss, it expands the choice. You can use metformin, extended release preferred, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and insulin. So this is if you have normal weight and you're not frail. However, with low body weight, even if you have fair renal function, you should use a DPP-4 inhibitor, and I recommend linagliptin, metformin with renal dosing, or insulin. See, so it really cuts down the choice. Then look at the people with high hypoglycemia risk and multiple comorbidities. The risk is particularly high if you're on an insulin sulfonylurea combination, if you've had hypoglycemia before, because then you have hypoglycemia unawareness. And if you have dementia, meal intake is poor. So with those people, again, you're limited. We would not generally recommend a sulfonylurea or insulin as the first go-to drug. So metformin, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. At the end of life, if you do need to use something, try and use linagliptin as an oral agent and low-dose basal insulin. If they're already on, let's say, multi-dose insulin, you can cut it back to basal insulin. And if they're on an oral agent, your safest bet would be a DPP-4 inhibitor, such as linagliptin. So just a caveat on when to avoid these drugs. I've covered most of this. We know metformin, not in decompensated heart failure. Stop it if the GFR is less than 30, unexplained, persistent diarrhea. GLP-1s, we know about the GI side effects, but remember, if somebody has gastroparesis, chronic constipation, recurrent ileus, it's not a good drug, okay? But you should use it if they have advanced cardiovascular complications or CKD. The same with SGLT2 inhibitors. Avoid if they're on dialysis, unable to drink independently. If they cannot hydrate themselves independently, then you're at risk. And if they have recurrent genital yeast infections or recurrent UTIs, fractures, okay? And stop 5 days before an elective procedure, because these people can get euglycemic ketoacidosis. However, SGLT2s are excellent drugs for heart failure patients. If you have CKD, they're recommended. And DPP-4 really avoid if unexplained GI symptoms. Basal insulin depends on the support system, and is there support that the patient can give themselves or somebody can give basal insulin. Okay. And then mealtime insulin, we really want to de-emphasize the use unless somebody is really not well controlled with basal or GLP-1, because not only it's a huge burden on the patient, the staff, if they're in the community or assisted living setting, it's not even feasible, okay? The risk of hypoglycemia is high. So really be more vigilant about the concurrent use of sulfonylureas and insulin, okay? So looking at the earlier guidelines from the American Diabetes Association, how to intensify injectable therapies. If they're not adequately controlled on basal insulin, so at that time we were looking more at A1C targets. So in the older adults, instead of going to mealtime insulin, the recommendation is to add a GLP-1, usually if it's a weekly one. And the reason is you don't need perfect blood glucose levels all the time. So you don't need to have perfect post-meal or subsequent meal blood glucose levels. A weekly GLP-1 will provide postprandial control. And you can even consider, if control is good, to lower the basal dose. If that's not possible, then you have to add prandial insulin. And that doesn't mean all 3 meals. Add a small dose, like 4 units to the largest meal of the day, and see how you do in a couple of weeks. how did the breakfast 4 units work? Did it control before lunch? So really avoid using a mealtime insulin for all 3 meals, okay? And do small increases if you're increasing doses. 10% is fine, okay? So you can look at this in more detail. This slide, I think you can just, these are strategies to replace sliding scale insulin in the post-acute setting. And this came from our position statement in the 2016 on long-term care management of diabetes. And we can discuss this later, but the main thing is if the person is just on sliding scale, add it all up over the week or so. What's the average amount they're using? And convert 50 to 75% of that into a basal dose. If they're already on sliding scale plus basal insulin, which is the second row, then you see how much sliding scale insulin are they using in addition to the basal dose, and take about 50 to 70% of that and add it to the morning basal insulin. Okay, this is before you're going into mealtime insulin. If necessary, you want to cut back on the sliding scale. Okay. Now, sliding scale may not be terrible if they're on high-dose steroids for a short time. If they're septic, they need more than their usual doses of insulin or oral agents. But just remember, once they've recovered from that illness, the sepsis, the IV antibiotics, that try to go back to a more scheduled regimen where you actually stop the sliding scale. Now let's move to the use of neuroagents to improve cardiorenal outcomes. So these go hand in hand now. I don't think we can separate them anymore. So we know that 40% of people with type 2 develop chronic kidney disease. There's a 2 to 4-fold increase in the risk of cardiovascular disease compared to the general population. And heart failure, as we all know, is like the revolving door to the hospital and the emergency room for people with type 2. There's a great increase compared to the people without diabetes in the occurrence of heart failure. Now, fortunately, there is evidence of the use of drugs to improve these outcomes. So for cardiorenal comorbidities, the recommendation is if your GFR is less than 30, you can use a weekly GLP-1 like liraglutide or semaglutide, dulaglutide, because that has been shown, and I'll show you the data, to reduce cardiovascular outcomes and improve renal outcomes. The big thing is with patients with heart failure, whether it's systolic or diastolic or medium heart failure, which we now have a third category, that you can use an SGLT2 inhibitor. It's been shown to have much improved outcomes if the GFR is between 25 to 60. And I'll show you the data for that. You should not initiate an SGLT2 inhibitor if the GFR is less than 30. So it's complicated. I look up each drug each time to see what their GFR recommendation is. And even if you have a renal patient with significant proteinuria and advanced CKD, if you cannot use an SGLT2 inhibitor, you can use a GLP-1. So drugs like dulaglutide and semaglutide have even been studied in dialysis patients. Okay. So I'll show you some data now on the use of these drugs and where there's been evidence of benefit. So SGLT2s and GLP-1 receptor agonists, are they equal in the treatment of diabetes? So here the outcome we look at is MACE, major adverse cardiovascular events like cardiovascular death, MI, and non-fatal stroke. So just the asterisk ones, if you look at the top, it's all the GLP-1 receptor agonists, okay? So the ones that have shown benefit are in the LEADER trial, liraglutide, semaglutide, and albiglutide, as well as dulaglutide. Those ones have shown benefit. The others have not shown convincing benefit. When you look at the green, this is the important area with SGLT2 inhibitors. As far as major cardiovascular events, empagliflozin and canagliflozin in the EMPA-REG and CANVAS studies have shown benefit, okay? Dapagliflozin was not so convincing with MACE. Now, if you look at all the DPP-4 inhibitors, which are commonly used and well tolerated, actually, They don't do much for cardiovascular events. They're neutral in terms of improving cardiovascular outcomes. So that's the downside of the DPP-4 inhibitors. Let's look at all-cause mortality. Same thing, but in the red are the GLP-1 receptor agonists, and liraglutide is the only one that's shown convincing benefit here. Semaglutide, there's still data coming out. I'm not quite sure about this point. And in terms of all-cause mortality, empagliflozin in the SGLT2 category has shown benefit. The DPP-4s are still neutral, no real benefit in terms of mortality, all-cause mortality. Now, what about hospitalization for heart failure? The main convincing benefit comes from the SGLT2 inhibitor category. All three drugs have shown a reduction in hospitalization for heart failure. The one, in terms of DPP-4 inhibitors, they're not really recommended for heart failure patients, but just remember, if somebody's on saxagliptin, the study that was done with saxagliptin showed that there was a worsening outcome. So if somebody's on saxagliptin, I would stop it. So that's something. The others are neutral. Remember that DPP-4 inhibitor increases GLP-1 in the gut, and a GLP-1 receptor agonist is GLP-1. So you cannot combine both of those together, okay, because they have similar or the same action. So what about studies in the elderly? So people often, sometimes they just automatically rule out the use of SGLT2 inhibitors in older patients. Well, this outcome of the SOUL study, and I apologize for the graphs, they really couldn't get them any clearer. But they looked at over 700 patients over 70 years old, and they were started on the various SGLT2 inhibitors and as an add-on to metformin or basal insulin or other drugs. 23% did discontinue treatment due to UTI and decline in renal function. There was a significant reduction in A1C from an average of 7.8 to 7.1. Now, of course, in the long-term care setting, that might not be our goal. Importantly, the GFR remains stable in these older adults over time, and significant reduction in urine protein excretion, which is one of the things we're trying to improve. And the people over 80 years old actually had significant improvement in A1C values without renal function alterations. So overall, it was pretty well tolerated in older adults. Now, I grant you this was not a nursing home study. Okay, but I think you could select the people who could tolerate this. So now let's look at the multiple studies adding up to 93,000 patients or older adults and the use of GLP-1 receptor agonists. Where were they beneficial? So this is less than 65 and over 65-year-olds. So I just put blue arrows. In the over 65-year-olds, they were beneficial in terms of cardiovascular death, not in the under 65-year-olds. So that's a plus. They were beneficial in the stroke outcome, okay, but not convincingly in the less than 65, but in the over 65, there was benefit, okay? So this is just outcomes in older people with GLP-1 receptor agonists. When you look at the same kind of population, if you look at the use of SGLT2 inhibitors, where was the benefit? And I think I already showed you there was some mortality benefit in SGLT2 inhibitors in the under 65, not in the over. But in cardiovascular death and heart failure, both under 65 and over 65 had a benefit. Now, when SGLT2s were used, I've showed you data on heart failure benefit with SGLT2 inhibitors, and definitely improvement in renal outcomes at all ages, less than 65 or not. So what are renal outcomes? Reduction in proteinuria, doubling of creatinine, and time to renal dialysis therapy. So SGLT2 inhibitors are definitely beneficial. They're even now used in CKD patients who do not have diabetes. And of course, they're used by cardiologists and people with and without diabetes at any stage of heart failure, because they have far more effects than just the reduction in blood glucose levels. So moving on to the use of diabetes technology, just seeing how we're doing for time. I'm going to focus on the use of continuous glucose monitors. And now instead of A1C, I think we will soon be getting used to one-page reports from CGM devices, either from online reports or from the readers themselves, to look at the ambulatory glucose profile. We're going to be looking at the time in range, because the more you're in range, the fewer the microvascular complications. That's what has been studied. And we'll also be able to see how much of the time is above and below target to really micromanage the regimen. Is it a postprandial? Is it a bedtime problem? Is it a fasting problem? Is there just too much overall variability? So this tells us much, much more than the A1C. So I want to show you this example of two patients with an A1C of 7%. And by CGM, you could see that the patient on the left, even though they had 7% A1C, they were only in range 40% of the time. Whereas the patient on the right with the same A1C was in range 70% of the time. So it's that minute-to-minute glucose, the variability, the diurnal variation that matters. It's no longer just the A1C. That it doesn't tell you enough about what's happening to the patient. Here's an example of a typical glucose report that you can print online if you can get access to the patient's data. And some of the readers, like freestyle readers, actually have this report very nicely in the reader. And you can email that to yourself or send it, to your printer. So the green is the time in range, okay? Generally, the time in range for people with diabetes is 70 to 180. Now, that's not to say for the nursing home patient, that should be time in range. And you can go into settings and adjust the time in range. Okay, I have patients who are 100 to 200, 100 to 180. If you set it too low, there is alarm fatigue, because if there are too many lows, patients tend to turn it off. And also you have to increase that low level. I think 70 is too low for most older adults. And we're trying to figure out now through a consensus group, what should the time in range, what should the settings be for CGM for older adults? This is a general recommendation. So the yellow is the time above range, okay, which is above 180 to 250. Again, that can be modified, and orange is above 250. The red is hypoglycemia. Ideally, you do not want to see any red in an older person. In a younger patient, maybe 1%, okay, of less than 54 and less than 4% of hypoglycemia, stage 1, less than 70. But in an older person, you really don't want to see much red at all, okay? So this is 14 days of use of a sensor, and that summarizes the data. And just to show you the metrics, just the same thing that I showed you in there. One of the things you can get from a CGM report is a GMI, glucose management indicator. This is from thousands of data points of glucose levels and A1C. This is a calculated A1C. So you don't need to do an A1C. If you get a GMI on your report, that is your calculated A1C. A lot of patients don't know that, and they're really amazed when they actually see this. You can't use this day to day. You need at least 14 days of data to calculate a GMI. The variability is important. Glycemic variability, we recommend less than 36%. Okay, and then time above range, time in range, etc. You have this. This is higher than 250, which really don't want to see much of. Okay. So the trick is choosing the right technology for the right patient. If you have a healthy person in the community, they can use a real-time CGM or a CGM where you intermittently scan CGM, depending on their preference. And the goal for a healthy patient, so this is Dr. Munji's paper, and she's really It's a consensus recommendation that the time in range, see, it's a little higher than 70 to 180, 90 to 180 to protect our patients from severe hypoglycemia. And we want to avoid all hypoglycemia. Now, patients with intermediate health problems like 5 comorbidities, mild cognitive impairment, or moderate, and some dependency in IADL. So I think of these like the assisted living patient. So what could you use? If CGM is preferred, then and it could be very helpful to the caregiver. They could use real-time CGM, which is, gives you every 5-minute readings, and or you could use intermittently scanned, but then somebody, including the patient or the staff member, would have to learn to do the reading. Here, the time in range is a little bit more liberal, 100 to 200, okay? And again, avoid all hypoglycemia. And those are in poor health, like a long-term patients, severe cognitive dysfunction, you can use intermittently scanned CGM, so the staff member can scan it to avoid finger sticks. So ISCGM is intermittently scanned, okay? And for these patients, they don't need CGM all the time. You can use a professional CGM, which is something that you can just put on a patient, a sensor for 14 days, just to see where are the problem areas, okay? These patients might not need a CGM all the time. I'm going to skip this. Actually, I'm not going to skip this. These are just targets for older patients. Time above range for younger people in type 1, we think 5%. Can be above 250. It's a bit more liberal for older people, less than 10%. See, this is the big difference. Time in range for young people with diabetes or middle-aged people is over 70% should be in range. For older people, it's recommended that 50% should be in range, but there's a lot of argument about this. Is this necessarily appropriate for older people? So there is now a group that I'm part of. We're trying to decide from the evidence, what should the time in range be for various older people, classes of older adults? So of course, the advantages in the post-acute long-term care, think about all the finger sticks you would save and the staff time. And think about patients in room isolation. This would have been great during COVID, when people either didn't get enough glucose checks, got too many glucose checks, in and out of room isolation. CGM has been shown to improve detection of hypoglycemia, and I'll show you that. And it could even help in end of life if that's a problem area. You can also use CGM to evaluate multiple patients in a facility, because you can have online access to their data, as long as they all have sensors and you have access to that. And this might help in transitions of care, because if they were using a CGM before, you should get them started on it. Now, this is easier said than done, of course. Now, many of you are familiar with a CGM. A real-time CGM is continuous display of glucose levels. The Freestyle 3 is now able to do that, and Dexcom can do that. Intermittently scanned is when you have to swipe the reader over the sensor, and that was the same with the older Dexcom versions and the Freestyle 2. Professional CGM is something that you can apply. You can buy the sensor yourself, or the clinic owns it. You apply it to the patient for 14 days, and then to see where the problem areas are. Okay. So in the outpatient setting, the use of technology is a problem. I find some of our older patients prefer the handheld readers rather than the phone app. Some are very savvy with working with the phone app. So with Dexcom, each sensor lasts 10 days. And so you need 3 per month. And that is, you also need to prescribe a transmitter that hooks onto the sensor, okay? And now we have Dexcom G7, which is a very smaller sensor, less warm-up time, Same 10-day period, but it has, if you run out and you haven't replaced the sensor, you have an extra 12 hours. And it's one of the most accurate sensors in the market right now. For all these sensors, you have to remove them before an MRI, CT, or any surgical procedure requiring diathermy. And soon this, well, some sensors already, like Medtronics has a sensor that is talking to the pump and the patient doesn't have to do anything. I'm not really versed in the use of that, but that's my goal. And Freestyle 3 is the latest Freestyle sensor. It's very small. Warm-up time is still an hour. It's changed every 14 days, but you don't need to scan it with a reader. It can, if you have an app, it gives you minute-to-minute readings. I think it's every minute, okay? But it probably won't be compatible with an insulin pump just yet. So I'm going to skip that. I think we've talked about that. So just to show you a case of somebody with nighttime hypoglycemia. So it's a 74-year-old woman with recurrent nighttime hypoglycemia, but kept switching off her alarm because of alarm fatigue. And here's the nighttime hypoglycemia. This is 9 a.m., this is 6 a.m. So you see the nighttime hypoglycemia, you see 10% lows, which is very serious. And here you see, look at this, the GMI, her A1C is not bad, 7.5, but she has nighttime hypoglycemia. So what would you do in this kind of patient? You could reduce or stop the rapid-acting insulin at bedtime, which she was receiving. You can still reduce the basal insulin because this is causing early morning hypoglycemia. And then you see the dinner time is high. Post-dinner is high. So postprandial dinner is not well controlled. So after taking care of the hypoglycemia, you can then increase the rapid-acting insulin with dinner because she's still high into midnight, okay? But first, you've got to take care of this nighttime hypoglycemia. So I hope this gives you an idea of how to troubleshoot a patient once you get their glucose profile. And what about CGM use in the post-acute long-term care setting? What data do we have? There are quite a few papers, but they're small, and we've applied for a big grant to Abbott. Hopefully this will work for a large nursing home study to study the feasibility and the effectiveness of CGM, especially in the detection of hypoglycemia and improvement in management. The feasibility studies in the home setting that have worked. There's a study of 35 patients in Connecticut, in 10 Connecticut nursing homes by Dr. Lipska. And what they found was they detected nighttime hypoglycemia that was not detected by finger sticks. So hypoglycemia was very rare when they looked at finger sticks, but there were at least 4 patients who had less than 70. Hypoglycemia. And in this study, again, I won't labor it, it's 97 people in, I think, 2 long-term care studies, facilities. They used real-time CGM, and it detected a greater proportion of patients with hypoglycemia, less than 70, or clinically serious hypoglycemia, which is less than 54, as well as hyperglycemia. Okay. The thing that you need to note with point-of-care testing, the blood glucose levels tend to run slightly lower than CGM levels, okay? So with CGM, if it runs slightly high, maybe the real, not real, this is real too, the point-of-care glucose may be lower. So any lows we see in CGM, we really need to pay attention to those lows. Same study. So in the long-term care setting, of course, what affects the use of technology is the site of care. What is feasible? How comfortable are people using it? And also payment, of course. So the site of care matters. The selection of patients matter. Their hypoglycemia risk, where are they transitioning to? Facility characteristics will really be important. And many I don't have personal experience in our facilities of anybody successfully using CGM, but there are facilities which are heavily staffed with nurse practitioners, PAs, and who have made it their business to learn to use CGM, and they are using it. So facility, depends on staff shortages, the training of the staff, also the culture and relationship with clinicians, reporting, internet connectivity matters, and of course, knowledge and training. The frequency of medical visits will make a big difference. This could be very useful in people receiving steroids, tube feedings, who have acute illnesses. And the other thing is we don't have set policies. So how is this going to affect the survey process and state regulatory oversight? Dr. Auslander is talking to Medicare about some of the recommendations in the diabetes guideline. And we are not yet sure what they'll say about the use of CGM. Okay. And of course, payment issues are going to be big. Depends on the billing structure, because right now we have per diem billing. And in group homes, this would only be covered as durable medical equipment. So for Medicare patients, this is a durable medical equipment. And it is also covered by Medicaid for those who are disabled or less than 18 years. For other commercial insurances, how you would order CGM is through the pharmacy. Okay, but for Medicare patients, it's durable medical equipment. So the other thing is also who is covered for CGM. So initially it was, you had to do 4 finger sticks, or you had to be on 3 doses of insulin. Now you can be on basal insulin, but you can get prior authorization for CGM if somebody has serious hypoglycemia, multiple ER visits. If they have hypoglycemia unawareness, you can try prior authorization for that. And I've even got CGM for somebody on a GLP-1 receptor agonist. It depends on the insurance company and how strong a case is. And I just want to show you some billing codes because it's important we take credit for this. The billing level is for a startup training is about $61 for Medicare, 95249. For application of professional CGM, that's for 1 sensor period just to see how the patient's doing, where the problems are. That's $147. And for interpretation, this you can apply at every visit, 95251. If you look at their CGM reader, if you look at their app, if you download their glucose management profile, you can bill as an additional code in addition to your visit. And amazingly, we're actually getting paid for that. So I'm going to end here, and I hope we have time for some questions.
Thank you so much for such a, exciting lecture and the update. I kind of, reviewed and learned a lot. So I was checking up on the chat box and I didn't see any questions. So Liz, do you have any questions for Dr. Pandya?
Sure, I can start with one. In terms of trying to reduce sliding scale insulin coverage scales, I would think in facilities, providers and staff may be pretty comfortable with that type of order set or structure. As a medical director, any advice how to approach those conversations? Or
it's difficult. Yeah. I understand. It is difficult. Some people have managed to make it a quality improvement project, just like you track weights, pressure sores, ER visits, infection control, to make that a quality improvement issue that you can track monthly. The other thing I would suggest is you may not win this whole battle all the time, but pick a few selected patients who you're going to address. And I think step by step might be better. If you have an interested or capable nurse manager who can work with you, if you have a diabetes champion, and that, you don't need too much formal training for that. You pick a few patients at a time that you can work on to reduce the use of sliding scale. And the low-hanging fruit is people who are on low doses of insulin, who barely use any insulin when they're on sliding scale, or those who've had a lot of, highs and lows.
Okay, great.
That makes sense. Yeah, thank you.
Well, we have a question coming from Sweta. So what do you do if
Sweta didn't give me any warning. Okay.
Device beats the entire night. Huh.
Sorry, what was the question?
Yeah, it's a device, right? The
Day
continuous
and
flow.
night, day and night.
No, it's the, sorry, Dr. Pandya, what I wanted to ask, the continuous glucose monitor, if it is detecting hypoglycemia in the night and
All
it
the
keeps
time.
on beeping, I mean, what do you do in situation like that?
Yeah, so hypoglycemia, you can't do anything immediately unless they're trained to give low doses of rapid acting insulin. Let's say if it's over 250 all the time, you really need to then adjust the whole regimen because you shouldn't be getting to those levels. So that means contacting the clinician, right away. So the more important thing is the hypoglycemia.
Yes, the
If you get an
hypoglycemia, I'm sorry.
alarm,
Yeah.
So make sure you have orange juice or something at your bedside. So because what worries me is people say, oh, I walked into the kitchen and I got some orange juice. Well, that's asking for a fall or an accident to happen. So you have to train them. You have to look at their settings too. Maybe their settings are too sensitive or, so they're alarming if they're less than 100. Maybe you can make it less than 90 and they can tolerate that, okay? So look at the settings. But hypoglycemia alarm should not be ignored, but it means that the regimen needs to be changed. Sometimes it could be very simple. They're eating dinner too early, or they're not getting a bedtime snack, or there's too much insulin being given in the evening, or the doses of medications need to be decreased. Okay.
Well, we have many other questions here. So Ty, on the question that Sweta just asked, are false positive and false negative results a concern in these devices? And if so, which device will be the best option?
I'm not sure quite what is meant by false positive and false negative.
Any so blood glucose result readings like hypoglycemia is not a real hypoglycemia for those devices.
It generally is. This has been studied over years. All Freestar, Dexcom, and Medtronic's Guardian have sensors. They're reliable. There is a difference between point of care testing and CGM. CGM, usually the blood glucose levels report a bit higher, okay? But you have to be careful of drugs like aspirin. High-dose aspirin and vitamin C can change your glucose levels, okay? Change the readings.
Okay, thank you.
That's what you have to be careful. But it's not that there's no, no, these devices would not even be on the market so long if there were, there are sort of coefficient of, there are reliability statistics, but all of them are pretty reliable because what we're trying to do is not micromanage every blood glucose. We are trying to detect dangerous trends. Okay, we're looking at trends.
Right. So, and we have another question. Thank you, Dr. Pandya. So Todd, do you want to come off mute? Todd Goddard? Well, his question was, have you had any success using CGM for patients not an injectable for diabetes who have hypoglycemia?
No. I'm trying to authorize that in a couple of patients, and it's valid, especially if they have recurrent hypoglycemia and hypoglycemia unawareness, okay? So some patients have actually purchased a sensor because they're so worried. Dexcom has come out, I can't remember the name, but they've come out with a cheaper sensor which does not need a prescription. Okay, so patients can actually purchase glucose sensors, and the app is easy. You don't have to pay anything, to track it on your phone.
Oh, wonderful. And it's coming over the counter, right? There's a
Yes,
brand.
yeah. I wish I should have researched the name, but it's on the market now.
Great. So any other questions, Liz?
And there was a question, I think you guys wanted to talk about assisted living facilities, right?
Oh, yes.
And yeah, CGM would be ideal. We tried as well on a couple of patients. it's difficult. Is it going to get paid for? And we have to train the staff, right? That's the thing. Unless the patient is so capable. And there are patients who are very capable, who might end up in an assisted living facility. So there would be either durable medical equipment or a pharmacy prescription, depending on whether they're Medicare or not. You know, once they use it, if you have remote access, because you can go through the online links to actually get access to these studies. So it's not like the nurse has to call you every time, okay? But they can call you if there are a couple of alarms, and you can go on the website and see what their trends are. Okay, that's what I'm still struggling with. It's not always easy to do, even in the clinic patients. I have access to several patients' profiles, but some patients, you know, have trouble with their emails and so forth, so they can't give you access, or, you know, they can't type off the code, you know, or send you a code that allows you access. So we're still struggling with that part in the clinic, although some clinics are really much better set up to have remote access to patients who are using CGM. In fact, they would pick up things before the patient, you know, got sick, because they would start picking up worrisome trends.
So on that end, would you say this technology came to stay?
Yes, definitely. Yeah, I think it's definitely here to stay in the outpatient setting, and it will slowly move into long-term care. You see there's already guidance for control in older adults, you know, what is time in range. And the most persuasive thing is that, well, it'll save time, it'll save discomfort for patients, nursing time, equipment, multiple finger sticks. And you can see that we will be able to look at trends rather than rely on A1Cs. And even these AC and HS AccuChecks do not tell us everything that's going on, especially nighttime hypoglycemia. So
Right.
I think that the whole field of diabetes, what is good control, will change. It will no longer be what is a good A1C. It'll be what is time in range. I see that that's the way it's going. It's with the hurdle we have to get through is the, you know, the training, the usage amongst clinicians, staff, the coverage, you know, also what Medicare will decide.
Absolutely. I think we'll need a second part for this from this talk. I hope we'll
give it some time.
Yes.
Some of the highlights from this talk that I can take were, you know, the first line caregivers and nursing staff, they need more intensive diabetes management education, especially the insulin pump or the CGM is being utilized. We need to simplify, de-intensify the treatment and replace the insulin sliding scale, the sliding scale insulin. And the monitoring glucose system is a massive game change and came here to stay. So any other remarks? I want to thank
you. But I really appreciate the invitation, and it's nice to see so many familiar people.
Thank you so much
Thanks so much for being here.
Okay. Bye-bye.